Welcome, ladies and gentlemen, to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years. And today we're going to be talking about a relatively difficult situation called traumatic brain injury. And this video is basically for family members or loved ones of a patient in the intensive care unit with a traumatic brain injury. We're going to talk about some general sort of ways to think about things to help sort of get a family through this kind of situation, which is very difficult to get through. And then some basic science principles about traumatic brain injury and brain swelling. And then we'll segue into techniques and strategies that the medical team is going to be using to try and battle traumatic brain injury and its effects. And then finally, the role that neurosurgery can play in treating traumatic brain injury. So hang in there. I know this is a difficult time, but stay tuned for the video on traumatic brain injury. So unfortunately, I can probably say I've dealt with hundreds, maybe 1,000 traumatic brain injury situations throughout my career as a neurosurgeon. These are tough situations to be in, both on the family side and the doctor side. And the 20 or 30 minute conversation I would have with family members in the beginning, I found went a long way to helping these people get through a very difficult couple of weeks. Those conversations or meetings don't always happen. Either it's just not something the neurosurgeon likes to do or is good at doing or has time to do. Hopefully what we talk about here in this video is going to serve that purpose and help you understand or think about things a certain way to help you get through the next couple of weeks. So the first thing I'd like to say is that one of the most important things you need to do is have confidence in the team that's taking care of your family member. These people know what they're doing. You may not always understand why something is being done, and the person in the room at that moment may not be the most capable or able to answer a question about why something is being done. But the neurosurgery team and the critical care team typically know what they're doing. If your family member has not been transferred to another institution and they are in the hospital that you're in the intensive care unit that you're in, it's typically because that intensive care unit and those physicians are capable of taking care of this problem. So number one thing I'd say is be confident in the team taking care of your family member. The second thing I'd say is that rather than sporadically asking questions when they come into your head about what's going on, it's better to kind of write them down and then have regularly scheduled meetings with ideally the neurosurgeon or the neurocritical care doctor on a regular basis. And that would be much better than kind of asking questions on the fly to whoever's in the room at that moment. It'll give you an opportunity to ask those questions, as well as the opportunity for the medical team to kind of communicate where your family member is on the spectrum of how things are going. So that's a much better strategy than just sporadically asking questions at the moment. And the next thing I'd mention is that keep in mind that one of the biggest indicators of how a patient is going to end up after a traumatic brain injury is how they look in the beginning when they start out. So a patient who has a severe head injury that is in bad shape neurologically up front in the beginning, they're going to have a much less likely chance of coming out in good shape at the end of this. If they're in relatively good shape in the very beginning, the first 5, 6, 12 hours, they have a better chance of coming out ahead when it comes to permanent neurological injury. So that initial status neurologically is really important on what their chances are at the end of this. And then finally, I'd recommend maintaining an attitude of being hopeful, but at the same time realistic. So don't give up hope, and have confidence in your medical team to apply the most standard, recent, best practices for treating traumatic brain injury. But at the same time be realistic that injury to the brain is a serious problem and can lead to serious consequences. And those consequences can include the patient not surviving, as well as, even if the patient survives, some type of serious or permanent neurological problem. So keep those two things in mind about being hopeful but realistic. And those are really kind of sort of general, medical things to think about when you start to approach the next couple of weeks of dealing with this kind of injury in your family member. So a couple of other non-medical things to take into account or think about or realize in these kinds of situations is, number one, there is a chance that your family member may have to be sent to a different hospital after they arrive at the first hospital. And that's because the kind of care that's needed for traumatic brain injury, as well as the possibility of needing surgery for that, is relatively specialized. And a lot of hospitals that first see a patient don't have that capability. If that's the case, if the patient is stable enough, meaning that it's safe enough to transport them, you may find that your family member is being whisked away to another hospital, hopefully relatively nearby. The more rural the area, the more the chance that they may have to be life-flighted on a helicopter or an airplane or something like that. But just keep in mind that if your family member is being moved to another hospital after a traumatic brain injury, the most likely reason is that the hospital that they're currently in either doesn't have the capability or the capacity to handle that patient. So understand that that doesn't mean that your patient is not getting the care they need. In fact, it may mean that they are finding the care they actually need but can't get at that hospital by going to another hospital. So keep that in mind. The other thing to think about is that when your family member is in the intensive care unit, they're really not being taken care of by a single doctor or a single team. Usually the patient is being taken care of by a critical care team, and that is a group of doctors that specialize in patients who are very, very sick for many, many reasons. And then in addition to that, they'll be taken care of by a neurosurgery team. And that typically involves doctors that specialize in neurological injuries, such as brain injury or spine injury or things like that. Those two teams work in coordination with each other. Usually the neurosurgery team will direct anything related to treatment of the neurosurgical problems, and then the critical care team will take care of all the peripheral problems that are either already there from other injuries or crop up while the patient is in the intensive care unit. The lungs, the heart, the kidneys, nutrition, temperature, respiratory support, all those kinds of things are usually managed by the critical care service. And then also keep in mind that all the stuff that the neurosurgery team and the critical care team want to do is usually carried out by a lot of support teams. So the respiratory therapy team may deal with managing the breathing machine if the patient is on a breathing machine. The nutrition team may deal with, administering and deciding what kind of nutrition the patient will get. You've got people coming in to take blood. You've got people coming in to bathe the patient. You've got people coming in to manage the fluids. The nursing staff is going to be carrying out a lot of these treatment orders. Everything that's done, however, is usually under the direction of the critical care team and the neurosurgery team. So just something to keep in mind, that there are multiple cooks in the kitchen, so to speak. So a basic concept to consider or understand when you're thinking about traumatic brain injury patients is something called the black box theory or black box phenomena. And that basically describes the situation where the brain is considered to be a substance inside a box, and the box is analogous to the skull. And in that situation, when that box is a sealed structure, which our skull technically is, the contents inside that box, or the contents inside the skull, is subject to rules of pressure and volume. And basically the concept says that the pressure inside the black box, in order for it to remain the same, The volume inside the black box has to stay the same, and the box has to stay the same. If anything changes, and in the case of traumatic brain injury, that's usually the volume of the stuff inside the box, or in this case, the brain. If the volume of the material inside that box increases and the box is not allowed to enlarge, the pressure inside that box is going to increase. So the analogy for the brain is inside the brain you have a certain number of things: brain tissue, blood, and spinal fluid or brain fluid. So if any one of those things increase in volume inside the trapped skull, the pressure is going to increase. And if the pressure inside the skull increases, the function of that brain tissue can decrease, and it can kill the patient eventually. So an example for this would be bleeding. If bleeding escapes out of the blood vessels inside the brain and forms a hematoma, or a collection of blood inside the brain or on the surface of the brain, and that bleeding continues, if something else is not decreased inside the skull, the pressure is going to increase inside the skull. And that pressure can directly damage brain tissue because of direct pressure on the brain tissue, or if that pressure becomes higher than the pressure of the blood going into the brain from the heart, the blood flow will stop because it can't get past the pressure inside the skull. And that can ultimately lead to dysfunction of the brain tissue. Or if, for example, there's a blood clot in the brain from trauma, it can actually push the brain through certain spots inside the skull, various nooks and crannies or crevices where the brain can get squeezed badly because of pressure in another spot. And that can also lead to dysfunction of the brain and ultimately permanent neurological injury or death. So the black box idea, where any change in volume of any of the things inside the head will increase pressure, is an important thing to understand, not only on why things are bad with the patient, but what are the purposes of some of the interventions. So let's talk about that. So I'm not going to get too far into the weeds with detail about the science or biology of brain edema or hemorrhaging or things like that, but let's just say that head trauma is usually due to some kind of force acting upon the head of an individual. That could be a baseball bat to the head, it could be a gunshot wound to the head, it could be an acceleration-deceleration injury where the patient is in an accelerated motion and is suddenly decelerating, and the brain gets knocked against bony prominences inside the skull, or the forehead hits a windshield or something like that in a car accident, fall from a balcony, etc., etc. Ultimately, that leads to a handful of problems that can lead to a change in neurological status and the patient ending up in the intensive care unit. Typically, those three things that lead to neurological problems, coma, neurological deficit, are bleeding, and that bleeding could be intraparenchymal bleeding, which is in the brain tissue itself, hematomas on the surface of the brain, and that could be something called a subdural hematoma or an epidural hematoma, and then finally brain swelling, which can occur in a diffuse nature through the entire brain, and that's typically from an acceleration-deceleration type of injury, or in a focal manner where the swelling occurs around a localized area of injury. But all of these cases involve an increase in volume of the substances inside the skull doesn't change size, and the pressure inside the head increases. So focal or diffuse swelling, blood clots inside the brain tissue itself, or blood clots on the surface of the brain are going to lead to the reasons that your family member is in the intensive care unit. Let's take a look at some images or pictures of what that looks like on diagrams and then CAT scans. So let's take a look at these diagrams. The picture on the left is a normal brain pattern, and the picture on the right shows trauma. So the first thing I'd want to tell you is that these blue center shapes here is the ventricular system in the brain, which contains the cerebrospinal fluid. The fluid that is removed during a spinal tap is actually made in these areas, and that's going to be important when we talk about something a little later. And what you can tell is that that same space on this picture on the right is pushed off to the side. You can see that things look symmetric here. If you put a line down the middle, you'll see left and right look pretty similar. Whereas if you put a line down the middle here, this ventricular system seems to be skewed to the right side of the picture. And that's because of this ball of blood here, which is an intracerebral hematoma, which means a collection of blood inside the tissue of the brain. This can be caused by trauma, or it can be caused by other reasons, but we're talking about trauma today. So this is the location of an intracerebral traumatic hematoma. This is the location of an epidural hematoma, and this is the location of a subdural hematoma. I'm not going to get into the weeds regarding the difference between these two, but let me just generally say that an epidural hematoma is usually arterial blood, which means that it can occur faster and create more pressure. A subdural hematoma is usually venous blood. That can occur more slowly and can become, over time, a chronic hematoma as opposed to an acute hematoma. Acute means fresh and relatively recent, and chronic means older, lasting longer. Both of these can cause problems, but an epidural hematoma is typically caused by the shearing of an artery on the surface of the dura, which is the covering of the brain. And that's often caused by a skull fracture in the same area. A subdural hematoma occurs underneath the dura and usually occurs by shearing or tearing or stretching of the veins that bridge between the brain and the dura. That's why this can stay smaller and not spread, because the venous blood gets kind of sealed off because it's under lower pressure. These can tend to become bigger and cause more problems more quickly because they are arterial blood, and the pressure of the blood coming out of the artery is going to be much higher. But this is a good picture to demonstrate those three most common types of traumatic troublemakers: the intraparenchymal or intracerebral hematoma, epidural hematoma, and subdural hematoma. Now let's take a look at when you get diffuse injury to the brain and diffuse swelling, which is called diffuse axonal injury. So in the case of diffuse axonal injury from brain trauma, you basically get an acceleration-deceleration injury to the brain. The head suddenly stops after it's moving, and the brain kind of sloshes around inside the skull. So you can see in this upper left picture, the patient is hitting their head on something in the front. The brain slams against the front of the inside of the skull and then moves back and forth. That can cause trauma to little sections of the brain that are near certain parts of the skull. And then you can see this redness here. The arrows show that the brain can move back and forth. But on a microscopic level, if you look here, the white matter, which is deeper, and the gray matter, which is on the surface, are different densities. And when the brain sloshes around from trauma, the nerve fibers can get sheared and injured. That leads to a cascade of events that cause swelling. So diffuse axonal injury will typically show as little spots of bleeding all over the place, and then eventually swelling all over the place. So now let's take a look at some CAT scans, maybe some MRIs of what the intraparenchymal, epidural, and subdural hematomas look like, as well as diffuse axonal injury. So in this case, these are CAT scans of the brain, and on the left you can see an epidural hematoma, classic crescent-shaped like this. The reason it's crescent-shaped is the bleeding occurs on the surface or on top of the dura, and the dura is tacked to the skull in various places. So when the bleeding occurs, it's kind of trapped by where the dura attaches to the skull. On the picture on the right, however, this is a subdural hematoma. Underneath the dura is not tacked to the skull anywhere, so the hematoma can span the entire width or breadth of the brain surface. Usually venous blood and more slowly bleeding, usually arterial blood and faster bleeding. You can see the pressure effect of this blood clot because the ventricles, which are the fluid spaces in the brain, are being pushed. You can tell they're not perfectly down the middle. If you draw a line down the middle, the one on the left side of the picture is being squeezed and everything's being pushed to the right side. In the subdural, you can see a similar phenomena. Here's the ventricle on the right. The one on the left you can't see at all because it's being squeezed shut by all the pressure here. So on the left, epidural hematoma, on the right, subdural hematoma. Let's now take a look at an intraparenchymal hematoma. Okay, so in this picture, we see an intraparenchymal hematoma. So the blood on the CAT scan is bright white, and this blood clot is inside the tissue of the brain. It does not look like an epidural or subdural hematoma. And what you can see, which is kind of typical in this kind of case, is this tissue under the scalp on the right side of the picture doesn't look like it does on the left. That's because this is all bruised and injured. And that suggests that the primary impact was on this side of the head, and then this is the part of the brain that bounced against the inside of the skull here in the acceleration-deceleration injury. And that's why you've got bleeding here, even though the point of impact was over here. So this is an intraparenchymal hematoma. And again, you can see there is some pressure effect on the ventricle here. These two do not look alike. This one on the left is missing the top. And that's because there's pressure in this area. So that's an intraparenchymal hematoma. And finally, here we're looking at obviously intracerebral hematomas, but these are from diffuse axonal injury type injuries, where the entire brain was traumatized, multiple areas of hemorrhage, which are these little white spots. This picture on the left is a CAT scan during day 1 of the trauma. Lots of little hemorrhages, not a lot of pressure though. By day 2, these hemorrhages have expanded. The darkness around these hemorrhages is edema or swelling. Massive pressure on the ventricular system here. This black space doesn't look anything like it did the day before. So this is diffuse swelling all over the brain. And then this picture on the right is a different patient, but you can see the fractured skull on the right side of the picture. The ventricle system is pushed all the way to the opposite side. Lots of little spots of black coloration, which is actually air from the outside world. Lots of little hemorrhages, which are these little white specks everywhere. And then this is sort of this diffuse nebulous color of the brain is called ground glass appearance, which is consistent with diffuse edema or swelling or fluid in the brain tissue. You don't see the little squiggly lines like you do on the surface of the brain on the left-sided picture. Everything is smooth. The difference between the gray and the white matter, which is this lighter color and darker color, you kind of lose that differentiation here. So this is diffuse cerebral edema from a severe head trauma. And these are all consistent with what's called diffuse axonal injury or malignant cerebral edema. All of these are very bad prognostic indicators for how the patient is going to do. So next, let's talk about what kind of interventions you can expect on a patient that has head injury, and we're going to divide these patients up into those that are awake and can control or maintain their airway, and those that are not. One of the measurements of the level of head injury that's used commonly is called the Glasgow Coma Scale, or GCS scale. And in a patient who has a Glasgow Coma Scale of greater than, let's say, 8, is typically able to communicate and breathe on their own. So in that patient who has a Glasgow Coma score of greater than 8, they may be in the intensive care unit because they have a severe head injury, but they may not be on a ventilator or breathing machine, and they may not be going under some of the interventions that are reserved with patients that are in more trouble from a head injury. Some of the things to keep in mind, though, that in that patient who's still awake but has a severe head injury, there are going to be certain things that are done to try and minimize the consequences of that head injury, namely swelling. So number one, they're going to be in the intensive care unit, which has better nurse-to-patient ratios, and the patients in the intensive care unit are paid more attention to. Typically, the neurosurgeon is going to ask that the head of the bed always stays at around 30 degrees. Some studies have shown that optimizes blood drainage from the brain in the venous system, and that can help control swelling. So we don't want a patient with a severe head injury lying flat in bed. So you'll notice probably that the head of the bed is ramped up to keep them sitting up relatively. They're going to get checked on every 1 to 2 hours, which means the nurse will come in or the doctor will come in and say, "What's your name? Show me 2 fingers, wiggle your toes, what year is it, who's the president, what's 2 plus 2, that kind of thing." And that's very important because sometimes deterioration in neurological status can be very subtle, and it can start to show early signs or hints of that with a change in those answers. So they're going to be bothered a lot every hour or two. They're not going to get a lot of sleep. They're probably not going to be allowed to eat because any kind of vomiting can change pressures in the brain and cause problems with high pressure in the brain. So they're probably going to make what's called NPO, which means nothing to eat, but they will remain hydrated on IV fluids. And those IV fluids can't be just any old IV fluids. You want the IV fluids to be something called isotonic fluids, which are something typically like normal saline or lactated Ringer solution. And the reason for that is you don't want any abnormal fluid shifts between the inside of the blood vessels and the brain tissue. And that's why you want isotonic fluid, meaning it's the same concentration levels as the normal blood. And then the last thing that'll happen is that the patient will undergo many CAT scans. In the first couple of days, they may go get a CAT scan once a morning or twice a day. And that's then, again, to monitor what's going on inside the head, hopefully to catch something that might be worsening before they actually start to deteriorate clinically. So that's kind of what to expect in the patient that's awake and able to communicate. Keep in mind that regardless of all those things I mentioned that might be done, that patient may deteriorate. And as the bleeding expands or the swelling around the bleeding expands, the patient may begin to deteriorate, and they would then shift into the next category of patient, which would be someone with a GCS level less than 8. And we're going to talk about that in a little bit. And then usually, and this is an important thing to think about, peak swelling from a traumatic brain injury is typically in the first 3 to 4 days. And you can get a phenomenon called delayed cerebral edema or swelling, which can occur in a delayed fashion. So usually these patients, even though they may look fantastic, they're still at risk for swelling in a immediate or delayed fashion after their head injury, and that's why they may be stuck in the intensive care unit for 3 to 4 days, showing steady improvement, CAT scans that look stable or better, no problems with blood pressure control, able to maybe start tolerating food. As you know, if they're looking pretty stable and good or better over the next 3 to 4 days, they may be downgraded from the intensive care unit and sent to a step-down unit or the regular floor room. So that's the patient with a moderate head trauma, mild or moderate, GCS greater than 8. So now let's talk about the next category of patient, someone who's in a bit more trouble. One other thing to mention before we get into the next category of patient that I forgot to mention is sedation. The patient may have a headache, the patient may have other injuries that are causing them pain. Keep in mind that it is a tightrope walk for the clinicians or doctors to give enough pain medication or sedation to help with the pain and control blood pressure, but at the same time not give so much sedation that they lose the neurological exam. If the patient is so knocked out on pain medication that they can't answer questions properly, they can't stay awake, the physician or team could be fooled into thinking that that change is coming from deteriorating neurological status as opposed to just pain medicine or sedation. So family members are often very upset or concerned. Oh my God, my family member's got a broken arm and they're really in pain. You're not giving them enough pain medicine. Keep in mind that if they have a head injury and we are clouding the picture of their neurological exam because we're giving too much pain medicine, we may miss a deteriorating brain situation and miss the opportunity to intervene and save that patient, either save them from death or save them from a permanent neurological injury. So as a family member, keep that in mind. Sometimes the patient may have to be in some pain in order to preserve that neurological exam. And also remember, the consequence of losing that neurological exam or the patient being so sedated that they can't remain awake is that now they will shift into the next category that we're now going to talk about, of the patient with a much severe head injury. So your family member was in a car accident. They arrive in the emergency room. At first, they may have been awake and able to show two fingers and tell the doctors their name, but they soon start to deteriorate. The CAT scan in the emergency room shows a large hemorrhage inside the brain tissue, and the patient is no longer following commands. That means they have now progressed into a severe head injury status, and things are going to look a little different in the intensive care unit at that point. Because they're not awake enough to protect their airway, meaning keep the airway open and not inhale their saliva, or vomiting and not being able to protect their lungs, in order to maintain adequate oxygenation and prevent lung injury, the patient will be intubated, which means that a tube is put in their lungs and they're attached to a breathing machine. That breathing machine allows the physicians to control very specific things with regard to how the brain is taken care of. So that breathing machine will be used in the treatment of the head injury. The second thing that'll happen is there'll be a tube put in the patient's nose into their stomach, and that's important to decompress the stomach as well as to give medications. There's an old saying in critical care is, if the gut works, use it. So eventually the patient is going to need nutrition. It may be preferable to give them medications through their GI tract as opposed to the IV. So having that tube in the stomach is going to serve multiple purposes. They're going to be in the intensive care unit, as we said, with the head of bed 30 degrees. They're going to have a catheter in their bladder. That not only helps the bladder empty, prevent the bed from getting messed up all the time, but it's also going to allow measurements of the urine volume as well as the contents of the urine. Also important in understanding and managing fluid status, which is important for brain swelling control. They're going to have likely a IV in an artery in their wrist, or what's called a central line, which is or a central line, which is an IV in usually the neck or shoulder blade or clavicle, collarbone area, in order to give access to the large veins in the body, as well as measure pressures. The IV in the wrist is an arterial line, which is very important for measuring arterial blood pressure. Again, important in managing fluid status and understanding the perfusion pressure, which is the pressure of blood flowing into the brain, which is important in keeping the brain alive and healthy in the setting of swelling. The patient's going to have possibly a collar around their neck, because if their head injury was severe enough to cause that much of a brain injury, they may also have a neck injury, and because they are not awake to follow commands, we can't be totally sure that the neck is not injured, even with CAT scans and x-rays. So the patient may remain in a collar around the neck until they can be woken up enough to follow commands. So that's typically what you're going to see in this more severely head injured patient. The breathing tube in the lungs is not very comfortable, so the patient will likely be heavily sedated. And that sedation, although it will cause the neurological exam to be lost, It can help control brain swelling through lowering the metabolic demand of the brain cells because they are suppressed with sedation to a certain level. And that can help with brain swelling. So that's kind of the picture of what you're going to see on a patient with a severe head injury. There is also the possibility that the sedation may be stopped for certain periods of time or intervals to attempt to get a neurological exam. The typical medication that I would like to use in the ICU is propofol to sedate the patient. It's a very fast-acting drug, so if you turn it off, it wears off pretty quickly, and you can try and get a neurological exam. So every 6, 8, or 12 hours, the nurses may turn off that sedation, give it some time for the patient to wake up, and then try and get them to show 2 fingers or open their eyes or follow commands. And then even if they do that, the medication will then be turned back on because it's pretty uncomfortable to have a breathing tube in your lungs and be awake. So now we've talked about the 2 kind of pictures you're going to see as a family member of a mild to moderate head injury versus a severe head injury patient. So now let's talk about a little bit more specifics about the kind of interventions that are done to treat brain trauma. So you can understand why physicians and the critical care team are doing some of the things they're doing. And when you have your meetings with them, some of the things they may be talking about, and this will maybe help you understand a little better about the parameters that they're talking about that they're adjusting the treatment options on. Once we go through those issues, and I'm not going to try and get too detailed about that, we're then going to talk about the role where the neurosurgeon might have to come in and do some surgeries. And those are typically, last-ditch efforts because surgery is always a last resort. So try and understand that medical non-surgical management is going to be what's undertaken first in an attempt to avoid surgery. But in some cases, the brain injury is severe enough or the brain swelling is severe enough that the typical non-surgical treatments aren't working and the brain injury is progressing. If that occurs, the surgeon may call you in and say something like, the patient's deteriorating, we're running out of options medically to treat this brain injury. We've got a couple of options surgically of what we can do. And next we're going to after we talk about the details of the interventions, we're going to talk about those surgeries and what the goals are of those surgeries, what the risks and benefits are, and then what to expect before, during, and after those surgeries. And that'll probably be enough to wrap up this video. So let's now talk about the interventions that are done to treat brain injury and why they're done. So in a patient with severe head injury, they will be in the intensive care unit. Keep in mind that some of these interventions that we're going to talk about may have already been applied or attempted in the emergency room. But in the patient with severe head injury, if they did not immediately go for surgery and they made it through the ER and they are now the intensive care unit, they will have all of the interventions that we already discussed for a mild to moderate head injury. But in addition to that, they will be most definitely intubated and on a breathing machine. They will most likely have been given seizure medicines, and they're going to be monitored for changes in neurological status and worsening of brain swelling or worsening of bleeding if they already got bleeding on a CAT scan. So how is this monitoring done? Well, as we mentioned before, they're not going to be able to follow a neurological exam because they're on a breathing machine. If they're on a breathing machine, it means they can't talk, and because they're so uncomfortable, they're going to likely be sedated or paralyzed with medications, and then once that happens, the neurological exam is lost. So one way to follow neurological status is, as we mentioned before, stopping the sedation periodically and checking a neurological exam. That's not very accurate or helpful, especially depending on what kind of sedation is being used. So the next intervention or a monitoring opportunity is through the use of what's called a intracranial pressure monitoring. And that is basically a gadget that tells the critical care team and the neurosurgeon what is the actual pressure reading inside the skull. That can be done using something called a bolt, which is placed through a small hole drilled in the skull, and then a little electrode is placed into the brain tissue, and that transduces the pressure to a number on the screen in the television monitor above the bed. That is very good at looking at the pressure, but it does not provide you with an opportunity to drain fluid from the brain to treat pressure. So a bolt is usually used when you can't do the other pressure monitoring option, which is called an intraventricular catheter. So let's give a brief discussion of why that works before we sort of talk about what it actually is. So the fluid that is actually removed from the spine when someone gets a spinal tap is actually made in an area of the brain called the ventricles, and these are fluid spaces in the brain. And there are 4 sort of chambers of fluid spaces in the brain that are connected through channels. And the little cells inside the brain that make this fluid is called the choroid plexus, and they make that fluid at a certain amount every minute, every hour. And that fluid circulates through the brain cavities, eventually down into the spinal canal. Eventually it gets absorbed into the venous system. So that spinal fluid is contained in a pocket in the front part of the brain called the lateral ventricles. And that lateral ventricle on either side can be accessed with a little tube. And that tube is called a ventriculostomy. And that is or external ventricular drain, EVD. And that tube can actually access that fluid space to not only tell the critical care team and the neurosurgeon what the pressure is inside the brain, but can also be used to drain that spinal fluid to treat that pressure. Remember, that rule about pressure and volume inside the skull is that if any one of those components in the brain, blood, spinal fluid, brain tissue, increases in volume, you have to have an equal decrease in volume in some other place in order for the pressure not to rise. So if the pressure is rising, for example, from increased bleeding or increased swelling, you could keep the pressure inside the skull stable by removing some of that fluid from the ventricle. And the way the external ventricular drain works is a hole is drilled through the skull through a small incision in the scalp. The covering of the brain is punctured with a little sharp instrument, and then the tube, which is like a soft silicone tube, is placed through the brain tissue into the lateral ventricle to access that cerebrospinal fluid. That tube is then connected to a drainage system, which not only allows fluid to be drained out of the ventricle, but allows pressure to be monitored and again put up on that screen on the television monitor above the bed. So in all likelihood, if your family member has a severe head injury, they are going to get some type of pressure monitoring device put into the brain tissue, either a bolt or an EVD, in order for the surgeons and critical care team to measure that pressure. Measuring that pressure is important because it tells them what direction the brain swelling could be going in the setting of a patient who can't tell them that things are worsening. As well as enabling them to calculate something called cerebral perfusion pressure. And cerebral perfusion pressure is basically determined through subtracting the intracranial pressure measured with the EVD from the mean arterial pressure. And the mean arterial pressure is likely going to be obtained, that number is going to be obtained through that little IV in the artery in the wrist. So if you take the blood pressure, you subtract the brain pressure, that gives you cerebral perfusion pressure, and you want the cerebral perfusion pressure to be above 60. If the pressure inside the head is too high and the blood from the heart can't get through that pressure, it means the brain everywhere is going to be starved from oxygen. Calculating that cerebral perfusion pressure enables the team to either decrease the pressure in the head, for example, by removing spinal fluid or brain fluid through the catheter in the ventricle, or raising blood pressure in order to get the blood pressure to push harder through that swelling. Again, important in maintaining oxygen delivery and blood flow to the brain. So be prepared for the surgeons to talk to you about the need to insert an intracranial pressure monitoring device. Although it may sound scary, it's very important in treating your family member. Okay, so let's say the patient has been in the ICU for maybe 1 or 2 days. They've been doing all the things we've talked about already. There's a ICP monitor or EVD in the ventricle of the brain to measure pressure. And all of a sudden, the critical care team or surgeons tells you that the pressure is beginning to rise, and they have to start performing some more interventions to fight that. Keep in mind, if the pressure rises either from the EVD that's put in or the patient's neurological exam deteriorates, more than likely the team's going to send your family member for another CAT scan to make sure nothing's changed there. It could show more swelling, it could show more bleeding. Regardless, if the patient has not reached a certain point, they may start to perform some interventions to fight that swelling. And I'm not going to get too far in the weeds about these particular interventions, but they include, for example, draining cerebrospinal fluid from that ventricular catheter, increasing blood pressure to increase blood flow to the brain. They may increase the breathing rate on the breathing machine, which changes the CO2 level in the blood, which in turn can change the diameter of the blood vessels in the brain to decrease swelling. They may start to add some osmotic agents through the IV, and osmotic agents are fluids or drugs that will pull fluid out of blood vessels, eventually getting the patient to kind of pee that fluid out. And those are things like mannitol or hypertonic saline. Both of those osmotic agents are basically concentrated fluids or a medication that concentrates the blood in the blood vessels, and because things are more concentrated in the blood vessels, it will pull fluid out of the brain tissue into the blood, and that eventually gets peed out. So that's another method of decreasing swelling. I touched on this earlier, but they may start to add sedation medications that make the brain electrical activity what's called isoelectric. And that basically means it suppresses the electrical activity in the brain down to almost zero, which lowers the metabolic demand of the brain tissue. That in turn can also decrease swelling. Now, a lot of these interventions are considered kind of last-ditch efforts. If the patient is not a surgical patient, for various reasons, either the problem in the brain isn't going to be helped by surgery, or other problems that they have in their body make it too risky for them to have surgery, a lot of these interventions are sort of Hail Mary attempts to stop or slow down the swelling for a certain period of time to allow the patient to get over that period of time of swelling. If these interventions do not work, the surgeon may sit down and talk to you about the need for surgery. So we're going to now segue into some of the surgical options for patients with traumatic brain injury and what they do and why they are considered or why they might work. So let's talk a little bit about that, surgical options for traumatic brain injury. So keep in mind, if you get to the point where the patient needs surgery for a traumatic brain injury, it usually means they're in trouble. Now, the surgery could occur, as soon as the patient arrives in the emergency room. A CAT scan is obtained, and that shows a big blood clot somewhere. The patient is not doing well neurologically. They may skip the intensive care unit in the beginning and go right to the operating room. That definitely happens often. Those are particularly more common for things like epidural hematomas and subdural hematomas, also with bullet wounds or traumatic skull fractures. But with more diffuse head injury from like diffuse axonal injury or generalized brain swelling from head injury, those may often lead to surgery a few days down the road after the intensive care unit, because swelling is now the problem as opposed to bleeding. So if we talk about surgery for brain trauma, I would kind of categorize that into three basic concepts, reasons, or goals on what you're trying to do when you take a patient to surgery for traumatic brain injury. And those are for the three most common surgeries that you would do for that. We're going to then, at the end, talk about a final surgery called a decompressive craniectomy, where you're not really trying to do much to the brain itself. You're instead trying to make the box bigger or the skull bigger to accommodate the brain swelling. But we'll get to that in a minute. So the patient's had a head trauma, and they've got one of those three common things going on. A blood clot on the surface of the brain on top of the dura, which is the covering of the brain. A blood clot on the surface of the brain underneath the dura, which is called a subdural hematoma. And then finally, a blood clot in the brain itself, taking up space, causing pressure, and then often swelling around that blood clot, taking up space, causing pressure. So in all of those cases, the neurosurgeon is probably going to sit you down in a room and talk about the fact that there is pressure occurring inside the brain that has to be released, or the patient's not going to make it. So the patient goes to the operating room. More than likely, they will have a very large incision on one side or the other, and that's called a reverse question mark incision. And it basically starts in front of the ear, goes above and behind the ear, all the way up to the hairline. And it's literally a reverse question mark. A piece of skull is removed that's typically pretty large, usually 6 centimeters, 8 centimeters large. And then that piece of bone is removed. The dura, which is the covering of the brain, is usually going to be what's seen next, unless it's an epidural hematoma. If it's an epidural hematoma, as soon as you take off the skull, you're going to see this big blood clot. If it's an epidural hematoma, that blood clot is removed and washed out. And once that blood clot is removed, you will likely see, or the neurosurgeon will likely see on the surface of the brain, a little jet of blood coming out of an artery that was torn on the surface of the dura. Again, the dura is that tough, thick membrane that covers the brain. It has arteries and veins in it, and oftentimes when a patient has a head trauma, that artery will get a little nick or tear in it, or if they have a skull fracture, that fracture will cut that little artery and blood will start to accumulate under the skull. When you find that little bleeding artery, you cauterize it with something called a bipolar cautery, stop the bleeding, wash everything out, secure the bone piece that you took off back to the edges of the skull, and then sew up the skin. There may be a little drain under the skin coming out that they usually take out a day or two after, just to keep blood from collecting underneath the skin and cause a lot of swelling. If it's a subdural hematoma, then once the skull piece is taken off, you're then going to see the dura, which is that thick covering of the brain, bulging out of the space that you just created by removing that piece of bone, and it'll be under a lot of pressure, and that's because there's blood underneath that membrane. You'll make a little nick in that membrane with a scalpel, then use scissors to cut that membrane in different sections, peel back the membrane, and then underneath you'll see a large blood clot. That gets kind of pulled out, washed out gently, and then you're going to see the surface of the brain, and typically you'll see an artery or a vein on the surface of the brain pushing out jets of blood or oozing blood that was the cause of that subdural hematoma. Those little areas are cauterized so the bleeding stops. The edges underneath the dura on the top of the brain are washed out with lactated Ringer solution or normal saline solution. Hopefully the brain is nice and relaxed now and pulsatile with the heartbeat, and you don't have what's called malignant edema or swelling, where the brain kind of swells out of that cavity that you created. Usually if you can get to that subdural hematoma fast enough, you won't have that malignant edema or swelling. Keep in mind that the younger the patient, the more likely you can have that type of swelling. Also keep in mind that the older the patient, the more brain shrinkage or atrophy can occur, and therefore the older the person is and the more atrophy they have, the more they might be able to accommodate a blood clot on the surface of the brain. So once everything looks nice and dry and nothing's bleeding, you sew the dura back up. Again, probably a little drain will be coming out of that space into the through the skin, again taken out in a couple days. Put the piece of skull back on and then sew up the skin. And that would be for a subdural hematoma. Now in the case of a hematoma inside the brain tissue, in that case what would happen is you would remove the piece of skull, open up the dura, and you still don't see a big blood clot, but the brain will be very swollen. And at that point, you want to make sure you're in the right spot to localize that blood clot the shortest distance from the surface of the brain. So that in turn might determine where the incision is made in the skin and where the skull is removed. So in the case of a hematoma inside the brain tissue, they may have something different than that reverse question mark type incision. Anyway, you find the location of that blood clot, make a small incision in the surface of the brain, cauterize anything that's oozing blood, and then you basically go down with some suction and cauterization until you get to the blood clot. And that blood clot will not be like flowing blood, it'll typically be like jelly because the blood is coagulated. And in that case, you just basically suck out that blood clot, and you technically don't really have to go digging around in the brain. You place the suction on the surface of the blood clot, and the blood clot will literally come out of the brain into the suction. Eventually, when you get out enough of that blood clot, the brain's going to start to relax and pulsate with the heartbeat, and you'll know and sort of be convinced that you've now decompressed that pressure. If there's any kind of big cavity where the blood clot was, you would cauterize the little blood vessels that might be bleeding. Make sure when you irrigate it, the return fluid is nice and clear, suggesting that there's no bleeding going on. And then again, you do the same thing you did for the other two surgeries I mentioned. Close everything up after making sure there's no bleeding, and then sew up the skin incision. Typically, again, there will be a drain coming out for a couple of days after the surgery. Keep in mind, if after you take out the blood clot, you might have seen on the CAT scan a lot of swelling around that blood clot, or when you take the blood clot out, the brain does not look nice and relaxed and pulsatile with the heartbeat, it may be necessary to actually remove brain tissue that's swollen to get to the point where the pressure is low enough. So keep in mind that some areas outside of the blood clot may need to be removed in order to get that pressure down. Hopefully this is not going to be in an area of the brain that's called eloquent brain, which is basically parts of the brain that the patient may notice. Speech, moving the arms or legs, vision, hearing, things like that. So those are kind of brief summaries of the three types of surgeries most common for traumatic brain injury that the patient might have to go through if they're either in big trouble up front or get into trouble because the brain swelling has increased over time or the bleeding has increased in time. So now let's talk about that final surgery that is really kind of the last-ditch effort for uncontrolled swelling from trauma. So remember we talked about that black box theory where the skull is the box, it doesn't change in size, and the brain inside the box, including brain tissue, blood, and spinal fluid, is the substance that can't increase in volume in any one of those categories without pressure going up. Well, if the pressure is severe enough, either immediately or over the first 3 or 4 days in the ICU, and all the other interventions we mentioned, like hyperventilation, osmotic agents, sedation, fluid manipulation, if all those things are not lowering the pressure or the pressure gets too high where the patient starts to get in trouble, you may have to do something called a decompressive craniectomy. And that is basically removing large portions of the skull, opening up the dura, and then allowing and not replacing the piece of skull, and then sewing back up the skin. And that basically allows the brain to swell out of that space where the skull used to be to accommodate the pressure that's going on. Now this is not a permanent kind of solution. You usually save that piece of skull in a deep freezer to be put back later. And remember I mentioned in the beginning of the video that the maximum peak of swelling usually occurs 3 to 4 days after injury. So what you want to do is day 2, you're running into trouble because of swelling. The patient is at risk of dying. So you whisk them to the operating room, take that piece of skull out, allow some space for that swelling to be accommodated, and then over the next 2-3 days, they pass the peak swelling period and the swelling starts to go down. So now at that point you would then go back with another surgery and put that piece of skull back on. It's usually not done that soon. You often can wait a month or 2 at that point to allow the patient to recover from all their injuries in general. Usually the patient will have to wear some sort of protective helmet while they're waiting for that piece of skull to be put back in because there is no protection of the brain over that area. You also, I mean, this is uncomfortable to see, but if the patient recovers and gets over that swelling, but they're missing that piece of skull from that surgery that you had to do, and you look at the patient, you're going to see a big sunken area in the head where the skull is missing and the brain is sunken, which is kind of a weird thing to see. But that decompressive craniectomy, where you remove the piece of skull, open the dura in a kind of a star type fashion, leave it open, and then sew up the skin, is called a decompressive craniectomy. And that is kind of the last ditch final effort that you would employ when a patient looks like they're salvageable from a neurological perspective, but the swelling is uncontrollable inside the skull, and you have to come up with some way to accommodate that swelling. So those are the 4 kind of surgeries that are done for patients with traumatic brain injury. Keep in mind, I did not go into significant detail about those surgeries. Your surgeon will do that as far as the risks and the benefits. We just don't have time to do that all in one video. This is just to give you a general kind of overview of what the main topics are to think about and you might be exposed to if you have a family member with a traumatic brain injury in the hospital. So I think that's probably enough for now. I know if you're watching this because you are in this situation, it is a tough time for you, so hang in there. I am going to be doing subsequent videos specifically on some of those topics. For example, specifically subdural hematomas, specifically epidural hematomas. So I'm going to go into much more detail about the mechanisms behind why these things happen, and much more detail about the surgeries and what to expect before, during, and after, and the risks, etc., etc. Also more pictures. So if you want to dive deeper into those specific topics, head back to the Your Go-To Doc YouTube channel and look for those videos. I apologize if I was kind of superficial on some of these topics or some of the details of this topic. But I just didn't want this video to get too long, so I hope that was helpful. I hope your family member does well. Remember, have faith in your team. Don't forget to ask questions, and if someone is not around to answer your questions, write them down so you don't forget them. Schedule some regularly scheduled meetings with the team so that you can get updates on what's going on and ask questions. Be careful about what you read on the internet or watch on the internet. Remember, follow up with your team to get the true advice about what's going on with your specific family member. So again, hang in there. I hope this was helpful. If it was, please like, please share, please subscribe to this channel, and don't forget, most importantly, stay healthy.